Hello everyone, my name is Nasif Paunta. I'm one of the clinical resource nurse in Adult Intensive Care Unit. For this session, we're going to be talking about ICU infections. Before we start, currently we are facing a great challenge in fighting the COVID-19 pandemic. To my fellow frontliners, healthcare workers and everyone, a gentle reminder to please always adhere to infection control precautionary measures, stay healthy and be safe, because we owe ourselves our safety. If you want to know more about the COVID-19 here in our hospital, you can go directly to EGO portal. On the right upper corner, just click the icon. From there, you can see updates, policies on how we handle patients who are actually suspected and confirmed case, and most importantly, how we can protect ourselves as individuals working in a healthcare setting. One of the saddest facts about infection is that it's everywhere. It could be at home, places we like to stay, at works, and of course, even us as a human being, we could be a carrier. As we all know, infection is the invasion and multiplication of microorganisms that are not normally present within the body, maybe local or generalized, which could be spread throughout the body. 1 in every 25 patients has an infection which is actually related to hospital care. On the side note, talking about infection, chain of infection is important to know, which deals how different kind of infections are being spread from human to human or an object to other things. The important point for us to understand is how we can be vigilant and be responsible individuals. Knowing this process itself, we can avoid, if not mitigate, the spread of infection. A piece of advice, always perform hand hygiene. Now let's discuss about healthcare-associated infection. Always remember that patient can acquire infection while receiving medical treatment in healthcare facility. More than 20% of all nosocomial infections are acquired in ICUs, which actually account for the substantial morbidity and mortality. In the ICU, we identified some of the infections. One is the ventilator-associated events, central line-associated bloodstream infection, or known as the CLABSI, catheter-associated urinary tract infection, CAUTI, multi-drug resistance organism, MDRO, surgical site infection, this is the SSI. So before anything else, what are those factors contributing in these kinds of infections? Now always remember, in the ICU, patients have actually having these chronic comorbidities, or we have this called secondary diagnosis, which actually patients might have hypertension, DM, or a lot of things. Some of the ICU patients as well have severe acute physiology derangement, which actually they require more than 1 catheters. The second, now let's talk about ventilator-associated events. VAE surveillance was initially introduced in National Healthcare Safety Network in 2013 by the Centers for Disease Control and Prevention, replacing surveillance for ventilator-associated pneumonia. And always remember that when it comes to VAE, patient must be mechanically ventilated for at least 4 calendar days to fulfill the criteria. And on the first day, patient must be intubated and connected to mechanical ventilation or mechanical ventilator. On the 3rd day, which is actually the earliest date of events, this is actually the date of onset of worsening oxygenation with the mechanical ventilator. Now, how we prevent this VAE? Now, we have the bundles. The first one is always remember that a patient, you should always elevate the head of bed 30 to 45 degrees. This is actually to prevent aspiration. Daily sedation interruption is very important as well. That's why, being a bedside nurse, you always have to remind the doctor. Daily assessment for readiness to extubate, which actually includes some consideration, like proper assessment, prevent and management of the pain, spontaneous awakening trials and spontaneous breathing trials, which actually the RT is the main responsible for this, the proper choice of analgesia sedation, the monitoring of delirium and its management, the early progressive mobilization and ambulation, and of course the family empowerment. Along with these bundles as well, peptic ulcer disease prophylaxis is very important because always remember an ICU patient, mostly they are critically ill patient, okay, and they are prone to have this gastrointestinal bleeding, or some of those patients, they can develop this bacterial colonization which actually propagate this respiratory infection. The next one is deep vein thrombosis prophylaxis because most of the ICU patients are immobile, they are heavily sedated. And lastly, oral care with chlorhexidine. This is very important. Please, you have to do it religiously. Now, another infection in the ICU that we always encounter is what we call the CLABSI. Common nowadays is the CLABSI. Now, CLABSI is actually a laboratory confirmed bloodstream infection. This is not actually a secondary to one infection at another site in patient where a central line or umbilical catheter was in place at the time of infection. Again, always remember, this is a line-related infection that is not related to the current infection of the patient after the 48 hours that the line is being inserted. So how do we prevent this CLABSI? The first one is the proper practices during the insertion. Now always remember, doctors, nurses, during the procedure itself, you should always perform hand hygiene. You should always adhere to aseptic technique, use maximal sterile barrier precautions, choose the best insertion site to minimize infections, prepare the insertion site with more than 0.5% chlorhexidine with alcohol, and place a sterile gauze dressing or sterile transparent semi-permeable dressing over the insertion site. For post-central venous catheter line replacement, always remember, if possible, replace central venous catheters inserted during a medical emergency within 48 hours. If possible, remove all pre-existing femoral lines within 12 hours of ICU admission. And always remember, femoral lines are the most commonly site for these kinds of infection. Next is, if possible, remove temporary central venous catheter before transfer to a general wards unless medically indicated. Now, CDC made these kinds of bundles specifically on accessing the central line. Now, being an ICU nurse or being a bedside nurse, we should always adhere to this. Okay, the first part of this bundle is always remember to perform hand hygiene, and you have to wear clean gloves. You have to perform the hand hygiene using alcohol for 20 to 30 seconds or soap and water for 40 to 60 seconds. Prior to cap removal, disinfect the cup and the hub that is visible and discard the sterile alcohol pad and the cup. Scrub the hub for 10 to 15 seconds, generating friction in a twisting motion on top of the hub using a new sterile alcohol pad for each hub. Next, clean the catheter minimum of 4 to 5 cm, moving from the hub towards the body by applying sterile alcohol pad with pressure to the catheter. The next one, hold the catheter while allowing the antiseptic air to dry a minimum of 30 seconds. Access the needleless port with sterile device only, and always remember, do not use any of the other devices. Disinfect the hub, scrub the hub again, same as step 3, before replacing a new cup. And lastly, discard the gloves and perform hand hygiene. Another thing about the CLABSI prevention is using the dressing, central line dressing. Now, how do we do this one? Again, the first part is always remember to perform hand hygiene and wear clean gloves. Now, hand hygiene should always be with alcohol for 20 to 30 seconds or using soap and water for 40 to 60 seconds. Now, head of the patient's The patient's head should be facing the opposite side. If the patient has tracheostomy, make sure that the dressing is not touching, okay? The tracheostomy dressing, if present, is not touching the central line dressing. Next, all dressing removed and disposed. Insertion site inspected for signs of infection. This is very important. Always, for whatever you do during the time of doing the dressing, always inspect the site for signs and infection. Remove your gloves, the one you used before. And this time, you have to perform again hand hygiene, same as the step 1. This time, you are going to wear a sterile glove. This is as per policy. Then you have to clean the site with ChloraPrep swab stick, 2% chlorhexidine or 70% alcohol, using a back and forth motion, creating friction over the entire area where the tegaderm will be placed. Now, site allowed to air dry prior to applying the dressing for a minimum of 30 seconds. You have to wait for 30 seconds before applying the tegaderm. Insertion site should be covered properly with tegaderm unless not available. You have to put the date and time. You have to write it in the dressing. And of course, lastly, you have to discard and the gloves and perform hand hygiene. Now, another infections that we have in ICU is what we call the multi-drug resistance organism, or the MDROs. MDRs are actually the pathogens that are resistant to first-line antimicrobial therapy, resulting in reduced effectiveness of treatment, expensive alternatives, or result in ineffective clearance of organism. Now, we have 2 classifications of MDRO. The first one is gram-positive bacteria. This is actually resistant to one key antimicrobial agent or 2 or more classes of antimicrobial agent. Now, a good examples of these gram-positive bacteria are the MRSA, or known as the methicillin-resistant Staphylococcus aureus, the vancomycin-resistant enterococci, or the VRE, the vancomycin intermediate-resistant enterococci, or the VIE. Now, the second classification is what we call the gram-negative bacteria, which is resistant to 3 or more classes of antimicrobial or one key antimicrobial agents. Now, example here are your MDR Pseudomonas, MDR Acinetobacter baumannii, the ESBL producing organism, which includes the strains of E. coli and Klebsiella. Now, how do we prevent this MDRO? We are doing the screening in the ICU. So how do we do this one? First one is we always do the tracheal aspirate early morning, especially for intubated patient. We have to swab as well for all patients that has any skin breakdown. If the patient is catheterized, we have to send the urine for culture. And always remember that specimen requisition must clearly state for MDRO, gram-negative rod. Now, what are the bundles for the MDRO? How do we prevent this MDRO? First one is again, always perform hand hygiene. We know already how to do it. Patient placement. If the patient is known to be infected, always isolate the patient. Contact isolation precaution is very important as well. Dedicated patient equipment is very important. Meaning to say, you only need to use the equipment only dedicated for one patient. Do not use other patients' equipment. Cleaning and disinfection monitoring is very important as well. And lastly, decolonization, which actually only applies for MRSA patient. Now remember, MDRO bundles is actually only for active infections, meaning say patient has an active infection. But if it is for surveillance only, do not do the bundle. The next infection that we have in the ICU is what we call the catheter-associated urinary tract infection, or the CAUTI. So what is CAUTI? A CAUTI is actually a symptomatic urinary tract infection or asymptomatic bacteremic UTI in a patient who had an indwelling catheter. Now, this indwelling catheter has to be in place for more than 2 days and in place at the date or event or the day before. So how do we prevent this CAUTI? Now, let's talk about the CAUTI bundle. The first one is, always remember, daily documented assessment for IFC. Meaning to say, you always have to inform your doctor, is it necessary to have this Foley catheter or not? You have to inform, it should always be documented. Next one is, for every time you perform procedure for this patient and every time you touch the patient's Foley catheter, always remember to perform hand hygiene. Foley's catheter has to be continuously connected, meaning to say this is a closed system. There is no reason that you have to disconnect or disrupt the closed system. Empty Foley's catheter bag using dedicated clean labeled urinal at the bedside. Okay, always remember, if you're assigned to one patient, single patient, always make sure you have a dedicated urinal, only specific for your patient. Daily metal care maintained by hospital care workers using soap and water. An obstructed floor is maintained. Drainage bag below level of the bladder and off the floor. And lastly, always remember, you have to secure the catheter properly to the thigh part. Now, the last infections that we identified in the ICU is the surgical site infections, or the SSI. So what is this? SSI is actually the infections occurs within 30 days or 90 days after an operative procedures that involves the skin or other parts of the body that is opened or manipulated during operative procedure. So how do we prevent this one? Now let's talk about the SSI care bundles. First one is, pre-op prophylaxis was given within 1 hour before surgical incision. So it is very much important to note this one. You can find this one in the form itself. The second one is discontinuation of prophylaxis antibiotic within 24 hours after surgery. The next one is appropriate hair removal using hair clippers. Next one is maintenance of post-op glucose control, which is actually applies for diabetic patients only. And lastly, maintenance of post-operative normothermia, which is actually 36.1 to 37.1 degrees Celsius. Now, if you want to know a lot of things about these bundles, you can just check the policy, which is actually entitled Care Bundles, and then you can see all the 5 infections with each bundles. Now, in the ICU, it is very much important to talk about the airborne infection isolation room. Now, always remember, AIIR is actually also known as negative pressure room. This is actually a single occupancy patient room that is being used to isolate persons with a suspected or confirmed airborne infection disease. Now, always remember that AIIR needs to be equipped with special air handling and ventilation capacity that meet the national and international standards. So what are these standards? The first one is, always remember that AIR must have a negative pressure equal or less than to 2.5 Pascal. This negative pressure room also must have a minimum of 12 air changes per hour, and air exhausted directly to the outside, if not, be recirculated through HEPA filtration before return. Now, how do we monitor this one? We have to monitor this one through visual indicators. So what are these indicators? The first one is utilizing the smoke test or the tissue test. And then the next one is audible manometer, permanently installed visual monitoring mechanism. So how can you find this one? Always remember, for every room, a negative room, it all has an anti-room. Now, outside the anti-room, you can find these monitors that clearly you can see how things are being monitored. Now, let's talk about the routine monitoring of our negative pressure room. First one is facility management, utilities, and maintenance department are using the monthly checking and verification of air change per hour and its pressure differentials. Then for us nursing staff who are actually being trained, okay, like for example your charge nurses, they have to monitor the air pressure daily, okay? And aside from this, they have to monitor the room itself also prior to patient admission needing airborne isolation. Now, always remember, negative pressure ventilation failure. So what is this? What happened, or what are we going to do if our negative pressure failed? Okay, now being a nursing staff, we should, number one, we have to apply or place surgical mask on the patient if tolerated. We have to keep the door closed at all times. Transfer the patient to another negative pressure room immediately, meaning to say, once you notify the facility utility management department, okay, and then they assess the room, and then they inform that the room is really failed for to maintain its negative pressure. Do this one directly, transfer the patient to another negative pressure room. Now, if AIR or negative pressure room not available, transfer to a single room with portable HEPA filter. And again, you have to notify the utilities and maintenance department, the infection control, and lastly, do not forget to document all information in the maintenance log form. So thank you so much, and if you want to know more about this one, you can just go on with our policies and procedures in our Ego portal. Thank you.